Hi everyone, I hope you're doing well. My name is Cameron Lynn and I am one of the senior trainers. Today we will be reviewing the PACES Syncope study to help with screening and enrollment in the emergency department. And the PI of the study is Dr. Daniel Nishijima. So a quick roadmap and overview of what we'll be going through. We will start with a background and some basic definitions of syncope and pre-syncope, followed by the purpose of the study. And then we'll consider what the inclusion and exclusion criteria that we will use to screen for the study. And then we will end with what the RA responsibilities are for this study. And I think you'll find that it's very similar to a lot of the other RC studies that we are already currently conducting. So let's first start with a basic definition of what syncope and pre-syncope are. As outlined by the one-page summary, syncope is a transient loss of consciousness associated with loss of postural tone with complete spontaneous recovery, while pre-syncope is the sudden onset of a sense of impending loss of consciousness without actual loss of consciousness. So here, the main difference between the two is that in pre-syncope, the individual does not actually lose consciousness, only feels that they might. Whereas in syncope, the individual actually loses consciousness, but is able to regain consciousness spontaneously. Another synonym for syncope is fainting, whereas pre-syncope is near fainting. Additionally, it is important to note that syncope patients must regain consciousness spontaneously without intervention. And while there are many causes for syncope, some of the following that were listed on PubMed are vasovagal syncope, orthostatic hypotension, carotid sinus hypersensitivity, neurological causes, endocrinological causes, and psychiatric disorders. And so if you're interested in reading more about those, I will link the paper and the source that I used in these slides. So what is the purpose of this study? There are two main objectives. The first is to learn more about the syncope and pre-syncope cohort of patients who come to the ER. And the second is to determine who is at low risk for poor outcomes at 30 days following a visit to the ER. And so because we are interested in that group of patients who is at low risk for bad outcomes at 30 days following a visit to the ER, part of the inclusion criteria is going to be that we need to be able to reach them with it through a working phone number and fixed address in the US or Canada. The patient also needs to be English or Spanish speaking and be 40 years or older and present to the ED with syncope or pre-syncope. For the exclusion criteria, there's going to be two major groups. The first is going to be any new serious diagnosis, such as death, significant cardiac arrhythmias, MI, significant structural heart disease, stroke, pulmonary embolism, aortic dissection, hemorrhage, anemia requiring blood transfusion, subarachnoid hemorrhage, cardiopulmonary resuscitation, pregnancy, acute surgical illness, major traumatic injury. And then the second is going to be syncope mimic. And examples are seizure, stroke, head trauma, altered mental status, hypoglycemia, intoxication, intervention to restore consciousness. And so the main thing to, I think, really take away from this large but not exhaustive exclusion list is that in the beginning, we defined syncope as a temporary loss of consciousness not related to any other condition. A temporary loss of consciousness associated with loss of postural tone with complete spontaneous recovery. And so in the syncope mimic, it's important that the patient is able to restore consciousness on their own rather than having an intervention to restore consciousness. And we do not want this to be related to another possible illness. And so we want to exclude these other serious diagnoses. For the RA responsibilities, how can we help with enrollment in the ED? So we want to screen for eligible patients listed on the track board by inclusion and exclusion criteria that we have just gone over. Some common chief complaints that you can look for beyond syncope and pre-syncope are, I feel like I was about to pass out, but do not screen for things like dizziness, vertigo, off balance, or weakness, as these can be often due to other conditions that aren't syncope. If you find an eligible patient, please notify the RCs of potential subjects. And then lastly, assist RCs with enrollment in any way possible, and they will direct you with that. I've listed the IRB number here, so you can go ahead and click into a patient's chart to kind of investigate further if you feel like a patient may be eligible. And if you have any questions, contact Abby, Logan, Donovan, Nicolette, or email the head trainers or senior trainers. Thank you so much for your time, and I hope you have a great day.